Just a quick question before we start. Can you see the banner of faces, or should I minimize that?
I can see the banner, but I think that's something I would control like on my end in terms of sharing the screen. So I can take the faces down. I just thought it might be nice to have them just so that whoever's like sharing their slides would be able to see what they're saying. It's up to you though. I can
Okay,
minimize it.
perfect.
Anyways, before we start, I would just like to say hello to everybody. I know that it was just really awkward at the beginning before we do the presentation, and just thank you, judges, for being here and for giving us the opportunity to give you our solution, present that to you. I'm not sure, Isabella, are we starting right now?
Yeah, it started recording.
Okay, Brennan.
And I will start once you start talking. I will start the timer. So
okay.
Yeah, give yourself some time, no rush.
Okay, awesome.
Awesome. So hello, my name is Brennan.
Hi, I'm Abbey.
I'm Bee.
And I'm Shahrzad.
And together we're Team 2. And today we're presenting New Brunswick Refugees, our interdisciplinary solutions to barriers in healthcare. Now, to tackle the issues concerning healthcare with inequalities experienced by refugees, we're going to discuss our short-term plan regarding Amina Khalid's case, our long-term solution, which is comprised of a 3-pillar plan approach, and as well how we are going to be moving forward together following the 3 years. Now, as a little bit of background information in the context of language barriers, patients who receive language discordant care are actually more likely to be more passive during their medical encounters, where they have a lower understanding of their health condition, as well as the follow-up treatment plan, and they're less communicative of their questions and concerns.
In terms of refugee mental health, refugees often have unique mental health experiences and needs. So before refugees migrate to a new country, they may have experienced traumatic events, and this may be the same during migration. They may be subject to physical harm. And then after migration, particularly unsponsored refugees like Amina Khalid may have a very stressful environment in terms of finding work and other resources. And so this can all contribute to mental health issues. However, if refugees come to Canada and are not experiencing severe mental health issues, they can definitely deteriorate during their stay in this country and end up with issues in the future. So this may be because of their living situation or trouble finding employment. And so they can really deteriorate if they do not have access to mental health care. And so refugees who are of lower socioeconomic status or unsponsored are more likely to live in rural communities because of the low cost associated with the community. And this subsequently decreases access to healthcare services and mental health care services.
So looking at our short-term solution, there are 3 main points that our team would change in how Amina's case started out. The first one would be increased patience with the translating technology. And we would want that technology being used right from the triage. So with a little bit more patience with that technology, the healthcare team could have understood Amina's symptoms a little bit better and have had a better idea of what was going on. Research shows that Google Translate has improved drastically. In one study in 2011, it found that Google Translate was 31% more effective in 51 languages. So we can only imagine how much of an improvement it's been to today. The second point that we'd make is we'd want the social worker to be on her case during her first visit. So right when she's admitted to the ER that first time. And we see 2 points of value there. One, it was mentioned that there was some increased stress with her children being in the room. And we thought the social worker might be able to take those children out of the room just while the medical examination and explanations were going on. And secondly, the social worker could connect Amina with these cultural and language resources sooner. So the same thing that happened in the second visit, but just a little bit sooner, because we see some real benefit there to that being done on the first try. And the third and final point is just making sure that Amina truly understands her treatment plan. So if a prescription was given again, taking some time to show her the resource that the doctor gave online, using Google Translate to translate that page, which is a feature of Google Translate, and letting Amina have her questions answered, and also explaining her next steps. So what we mean by that is, what should Amina do if the prescription doesn't work? Should she come back to the ER? Is there a physician in the community that she should see. Just really explaining the next steps as well.
Okay, so now we have our long-term approach, and the biggest part of our long-term approach are our 3 pillars. And the 3 pillars represent the 3 aspects that we believe we can make changes in that will help the future of the healthcare. So we have education, language, and community consultation.
So obviously we can't implement everything right off the get-go, even though we might want to. So we have everything spread out over this 3 years. The first point that I really want to draw attention to is the hiring of our refugee experience coordinators, or RECs. So these are public health professionals, and their jobs would be to implement this program and also to reevaluate and make sure that it's working past its 3 years. So these 2 positions we're hoping to hire would have an estimated salary of $60,000 annually. And we can see this funding coming from a combination of grants, provincial funding, and other similar funding sources.
So our first pillar is education, and I want to begin with cultural competency training, most specifically for healthcare providers, because implementing cultural competency programs into medical schools and degrees gives healthcare providers an education and practical guidance so that they have the ability to understand intellectual interactions and to avoid unconscious bias while dealing with patients. That way, no matter who walks through their door, they can give their best care despite any cultural barrier. It should also be required that healthcare providers who are currently practicing are given cultural competency training through a workshop that just requires sign up because the New Brunswick Multicultural Council already hosts it. Now, by looking at this graphic in the bottom right, we can see how educating healthcare providers of cultural competency training gives them information on health in these areas, which relates back to the delivery of patient care, specifically the treatment of refugees like Amina. Because there is excellent evidence that cultural competency training improves not only the knowledge of health professionals, but also their attitudes and skills, as well as positively impacting patient satisfaction. The next point is public health information. It is important that we source public health information through multicultural agencies to tailor the problems to these refugees, but also to get assistance in tailoring universal public health information to refugees. In hospital, for example, we need to take campaigns such as anti-smoking, women's reproductive health, and more, and make them available in different languages or as universal graphics for basic information. Then, we also need to consider improving online access to public health information. This is important because even though there are many who do not have access to online resources, there are also many who do. And it is easy for healthcare providers to print resources from online sources and give them to patients. But first, the information that the New Brunswick healthcare system is presenting must be available in a multitude of languages. This only requires a few simple changes to create a more versatile page, especially because other provinces, such as Ontario, already have public health sites, where with a click of a button, things such as COVID information on COVID-19, public health services, and more is available in almost 100 different languages. We have no excuse. This is an easy fix and gives refugees access to information on their conditions, or it can help them realize how their day-to-day habits affect their overall health.
As language is our second pillar, we are applying a language planning theory as it will aim to achieve our long-term goal in identifying language barriers at an interactional level and thereby developing a language accessing system at an institutional level. And we're doing this by using a framework called the quadruple aim method, which has been successfully implemented within Ontario's healthcare system to address 3 specific questions in the context of language barriers, as this framework is specifically designed to improve the quality, costs, and experiences of those accessing the healthcare system, as well as the healthcare worker experience itself. So who needs this service and in which language? Well, our team is implementing primary language data collection to be filed within the patient's electronic healthcare records. And this can be done upon the first medical encounter at a hospital or at a clinic, or when the refugee first registers for a Medicare card. Now, with this in their file, the patient's healthcare team will be aware of the patient's preferred language in discussing healthcare, as well as this data collection will be useful in better tailoring the language accessing system to the population that our hospital and our province serve. Now, who will provide these services? Well, our team will be implementing an accessible language interpreting service within our hospital and within provincial health, which will incorporate privacy, accuracy, and accessibility. Now, this the skilled workforce will be employed, which includes program management and IT, to, just like what Abby has said, to increase measures in public health information by creating multilingual patient education video animations. Now, what is the method of delivery for these services? Well, we have partnered with Telelanguage, a video remote interpretation tool, which starts at around 53 cents per minute, according to Telelanguage, and will be employed on an on-call basis. Now, this cost-effective resource will be accessible through provincial health networks such as Horizon Health and on their website to be accessible to healthcare professionals, and will also be linked to 811 Healthline for accessibility to those who require 24/7 accessibility, highly medically accurate interpreting services for over 300 languages, with those with a lower socioeconomic status or in both urban and rural communities. Now, in the case of Amina Khalid, all her physician would have had to do was go to the Horizon Health Network website, clicked on a telelanguage service icon that has been programmed, and then they would be redirected and connected to telelanguage. And with this, their healthcare experience has, for both parties, have been immensely improved and would have avoided the repercussions of language discordant communication in healthcare settings.
For our third pillar, we really want to focus on improving community-based services for refugees. So with refugees who are unsponsored, they often cannot access the services provided by New Brunswick Multicultural Associations and the New Brunswick Multicultural Council. So really the best solution for this is to increase the number of refugees that can be sponsored through these organizations. So the refugee experience coordinators that we have hired would conduct funding campaigns to increase funding, and this would subsequently allow more refugees to be sponsored and to access the services provided by these associations. And increasing funding will also allow associations to expand services to more rural locations, such as Amina Khalid. In terms of mental health, we really want to use a preventative strategy to prevent deterioration of mental health in refugees. And by increasing the community-based services, this will allow more access to the services and allow refugees to develop a more sense of belonging and community. But we also want to address refugees who already have mental health issues, and we propose doing this with the Canadian Mental Health Association of New Brunswick. So the CMHA of New Brunswick offers programs and workshops for various mental health issues at no cost and no referral needed. So the refugee experience coordinators could facilitate communication between the Canadian Mental Health Association and the multicultural associations to provide access to programs and workshops for refugees. However, we propose that they develop specific programs catered toward refugees and expand their rural services to New Brunswickers. And this would perhaps allow refugees who are less likely to come forward for help due to cultural differences or reduced stigma in their community to come forward if they have increased access. And so by facilitating communication between these organizations, we can ensure that all aspects, both physical and mental health care, are addressed. And by considering all the factors we have mentioned, we are promoting holistic individual and community health. In terms of moving forward together, we really want to focus on community consultation research. So the refugee experience coordinators can facilitate communication between universities in New Brunswick and multicultural associations to conduct qualitative research, and this could include methods such as interviews and surveys. And this will allow us to get a better understanding of experiences of refugees throughout the 3-year plan that we have created, and particularly understand barriers to healthcare that they may still be experiencing, and also what the province can improve on in terms of healthcare access. So professors in the health disciplines and sociology and psychology departments of these universities could apply for funding depending on their eligibility. So for instance, the Tri-Council funding for the 3 research agencies, and this will really allow the continuation of interdisciplinary approaches to improve access to healthcare for refugees.
So we anticipate 3 main benefits coming from the implementation of this plan. The first one being an improvement of healthcare experience for refugees, not only with general satisfaction of the healthcare system, but also in healthcare outcomes. Secondly, we know there will be a reduction in unnecessary ER visits and increased preventative care. Research shows that refugees and newcomers are more likely to go to an emergency room because they believe there's a higher chance of receiving interpretation services. This will no longer be an issue because interpretation services will be available in all public health across the province. So this includes community clinics and other such practices. And the final point is it'll make New Brunswick more appealing to potential newcomers. Right now, it's a goal of the province to increase the working class due to our aging population. And they're responding to this with attracting more newcomers. By implementing these things, New Brunswick will become a leader in newcomer healthcare, and we will be able to attract more people to our working force.
So thank you very much for listening to our presentation, and now we welcome the floor to any questions.
Great work, everyone. Yeah, if anybody has questions, we'll do 5 minutes for questions. That was right on 15. Very impressive.
Perfect.
So is there an order, or may I jump in with a question? Okay, for me to, okay. Have you considered with the third pillar, when you were speaking about the qualitative research aspect, something in the vicinity of like an ethnography?
So, sorry, what do you mean considered?
An ethnography? So the idea of an ethnography is that you go the reverse direction of, say, a random sample with a large set of observations, but instead you focus in tightly on a small community, which in this case, this is what we have, and you get a very fulsome type of concept around this group. This is something that often gets done, like ethnographers would start looking at this within the perspective of, say, homelessness. So have you looked at something like this with respect to newcomers?
So we haven't looked specifically at how large scale the study would be, but in conducting interviews and surveys, I think I completely agree with you, like using a smaller population, sort of a tighter community would allow us to get more advice and input from each individual rather than like a large based study where we may not be getting the full story. So that's definitely something that would be a better approach rather than a large based study.
Thank you.
I'd have a question then. That's okay. Shall I just shoot? Yeah.
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 Yep.
Cool. So I thought it was a fantastic presentation. I thought it was really nice, really clear, and I could visualize the solutions that you proposed in my head. There's a couple of questions that I had, particularly with the educational part, and I've spent many years trying to educate healthcare professionals in a variety of topic areas, mainly behavior and behavior change in my field. And there was one comment, sort of maybe a throwaway comment, but it said that it was an easy fix and there are no excuses to not do it. So maybe it's my naivety that I haven't found an easy way of communicating these issues of how do you approach things like cultural competency and how you talk to people and how you treat people and how you show empathy and all these kind of things. And is it really just education? Is it just that you need to raise awareness and give people more awareness and more knowledge, and then their healthcare practice changes?
So I think the comment more about it being an easy fix was more directed towards being able to alter our online resources, because that is already being implemented in different provinces, and that's kind of the aspect that's easy. But the education and the cultural competency training for healthcare providers is definitely, it's been attempted many times, and it's definitely not easy. It's hard to get people to change their ways and to think about things in regards to others, and especially when they've been doing the same thing for years. And I think that's part of the reason that education is part of our long-term plan, because we might not be able to fully change everyone's perspectives, but hopefully even if we can just change a couple, we can implement our other ideas and they all work together towards a better future.
That's a nice answer, thank you. So one thing that you did really nicely in the language pillar that you presented is you drew on theory, yeah? And there might be theories out there about how you change people's mindsets and associated behaviors that you could draw on within the first pillar, because usually we kind of know that just education, raising knowledge and awareness might not lead to people actually doing things differently in real life, because oftentimes they're, as you say yourself, habits and ingrained routines and ways of working that they have already established over long periods of time.
Show me the screen.
I've got one more, if I may. Yeah, thank you. So my second question is, what roles do refugees and newcomers play in establishing this work that you've just presented? Do you envisage them playing a role in building up these solutions?
They see at the bottom of the screen.
If I may jump in on that question. So with refugees, we expect them to, well, we expect ourselves to be engaging in a lot of research, whether it be from the ethnography and how to address the theories regarding how do we solidify our education plan with them. But in terms of the refugees, we really require their input. And we understand that the refugee and whether local ethnic communities, their populations are growing within New Brunswick. And with that, in order for us to better our plan to apply to future newcomers, we would like to also present that as a solution to a language barrier, to employ more refugees within the scope of the healthcare field to be able to help provide these services and be as a contributing input to how we can better it within the hospital itself, from a perspective of how, as an employee and as someone who undergoes the healthcare system. If that makes sense, yeah.
That makes sense. That was a nice answer. Thank you. That's the main questions I had.
Can I pop in with another? So this looks great. I'll echo Stephen's comment about, it's just well presented, and I like your approach. Now, I'm not this person, but I'll pretend I am for 1 second. I'll be the fiscal hermit crab, and I'll say, how much is this gonna cost us? I saw a couple numbers. I saw some salary numbers and a cost per minute with respect to the telephone aspects. So as a total, from a budget perspective.
Sorry, just to clarify, you're asking for a full total sum?
Yeah, like what's the budget looking like? Because policymakers need to basically present not only a great idea, but they also need to show government that this is also feasible within the financial constraints that New Brunswick especially is facing.
Does this include like the funding? Do you mean including the money we get from the funding agencies that we would apply for, or just other than like assuming we get funding? Sorry.
Sure. Well, you do the cost outlay. How much is it going to cost? And then, of course, if you have some grant money, this money can offset some of this. Otherwise, government needs to pony up on this. So how does that all look?
So our biggest cost,
Go ahead.
Sorry, our biggest cost is definitely the refugee experience coordinators, those two positions. So that estimated cost, we shot a little bit high at 60,000 annually. And that was just comparable to a public health officer position. And then a part of their position would be securing funding to continue it. And then the other larger cost would be the total lump sum of the telephone interpretation. And that's based on usage. So however many people are taking advantage of the service, it would be that based on the 53 cents per minute figure. So yes, a lot of the work that we did imply comes in through funding and partnership. And that kind of came in through our community and consultation section a little bit.
And in addition, sorry, we know that we have done some research regarding like government grants about that are involved specifically allocated for immigration costs. And if we were to collaborate with those people working under that group, then we will be able to try to allocate some money specifically to support our RECs. And whether or not, let's say we do have that, there is our team, as well as just what Brennan is saying and what I had mentioned earlier, just about the 53 cents. I understand that's not the whole concept, but it is little prices, but we could definitely focus more on how can we address things on an immediate aspect, and that would just be the immediate pricing of it.
And so am I understanding it correctly that the RECs, the RECs would be implementing all these 3 pillars? Yeah, that would be their main remit within that position, right? So the selection of the RECs would be absolutely crucial with this, program of work either succeeding or not succeeding.
Definitely. They would
absolutely.
definitely be the supervisors for all of this. We're definitely behind that, and we will help them with that. But for them, it is more of just how do we get this program from the ground up and build it up? Because it's not just going to be them. They are collaborating with a bunch of other teams. Like we've said, how do we implement the video animations within this team? How do we connect with the telelanguage team? How do we connect? So it's more of just like a branch work of people. So, but like you said, it is very essential that we hire the best RECs out there with background experience and in all of these issues, and with refugee, and they have that information background to definitely contribute to it with a more, with a definitely more like emotional connection to it as well, because everything can't just be like off the book. So
yeah, I definitely agree that hiring refugees who have been in New Brunswick for an X amount of years, who have experienced these disparities possibly, and who know the healthcare system well, providing them with the right education and then hiring them would be definitely a good choice compared to just hiring, let's say, someone with only a public health degree or experience.
Sorry, everyone, I have to chime in. It's been 10 minutes for questions. So if anybody would like to say anything really small to wrap it up, yeah?
Andrea's waving.
Our healthcare provider expert judge, would you like to ask any questions?
Just be known, we might be kicked out of Zoom right here, and it says 3 minutes and 30 seconds. While we wait for her to get her mic on, if she's going to, for the delegates, once we finish, if you could come back between 4:35 and 5:05 is when we will be doing networking with the judges, among other delegates. So you're free to go once we finish with this Zoom call. And we thank you very much, but I'll definitely wait for Victoria if she has any questions. And for the judges, we'll be doing the next presentation within the next few minutes. It is scheduled for 2:10. So once we get back in together, we'll hopefully have a seamless transition into Gather. And I think you'll be doing Team 3 Lounge.
Just say well done, Team 2.
Thank you very much.
Great.
Thank you.
Yeah, thank you, judges,
Yes.
for your
Thank you.
input, because we have been looking at this for a week long, and we really appreciate the comments and like the criticism to how we can make this better, even after this thing. So thank you.
No,
Yeah.
there was a lot of thought behind it, definitely. Well done.
Yes, I
Thank you.
echo same statements. Very well done, guys. Excellent.
If we want to wait a couple more seconds, I can see if Victoria. Oh,
Can you hear me?
Yep.
Okay, so my video's not working. I can't get my camera up and working. Okay, so you can hear me, so I can at least tell you can I tell you briefly what I thought? I know you don't have a lot of time. Okay,
Yeah,
go
we
ahead.
just have under 2 minutes, just so you know.
No, okay, well, I thought it was an excellent presentation. I thought it was very clear, concise. I thought your points were great, and they would really work in a healthcare setting.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
At least I'm glad you can at least hear my comments. Sorry about the camera.
It's all good.
No problem.
Okay.
It's difficult to work with Zoom sometimes, but okay, so thank you everybody. So delegates, we will see you back at 4:35 in the networking lounge, and judges and mentors and everybody else, if you could go back into gather and turn your mic and your camera on and go into team 3. And sorry, the presentations will be back to back, but hopefully that's okay. And thank you again. You guys had an amazing presentation, so you should be proud of yourselves.
Yeah.
Thank you.
Take care.
Bye everybody.
Bye.
You can just press leave, it'll go back to gather.
Thanks, everyone.
Bye everybody.